The best advice for all of us considering using DBS is to make sure we're selecting the right patients, or at least we are not selecting the wrong patients for this device, because it will harm the reputation of the device in epilepsy as a treatment modality for epilepsy, which could be valuable in a select number of patients. Now, how to get there? We get there through following the selection criteria that we talked about, and to have a rigorous follow-up on these patients, assessing the reasons, perceived reasons for success, and of course, the main causes of failure. For example, at Cleveland Clinic, since the approval of DBS, we started to collect a list of patients whom we think they are candidates for this device. How did we get there? The way we got there is to follow the pre-surgical evaluation protocol that we have. That is medically intractable epilepsy or pharmacoresistant epilepsy. That epilepsy, it is focal, it means coming from one or more areas in the brain. That the patient's epilepsy is not amenable to resective surgery, and that other treatment modalities, including RNS, are not the best for this patient population. For example, this patient population, a year ago, they would have been ruled out from any treatment except continue to try medication. So we collected this list over the last 6 months, and we have between, I think, 3 or 4 patients in this list now who are ready to be implanted when the device is launched in the market. And who, beside this, you may ask, well, are these patients, they have temporal lobe epilepsy, frontal lobe epilepsy, parietal lobe epilepsy? It's the mixture. It is patients who have bitemporal lobe epilepsy, patients who have parietal lobe epilepsy, left and right, or epilepsies that come in from one area, but it's very difficult to pinpoint exactly the extent of the seizure focus. Well, I think DBS, it is as a new treatment modality for epilepsy, it is exciting because despite all of the advances we've had definitely over the last 20 years, there is a sizable group of patients who continue to suffer from recurrent seizures, recurrent disabling seizures, despite everything we do. So we always are hoping for something that can make a difference in the lives of these patients. And DBS may give us hope, but we've learned to do this. We have always to temper our excitement and to be very deliberate in the way we select these patients, and we have very strict follow-up these patients to try to learn about our successes and certainly to adjust to our failures and hopefully refine in the next 6 to 12 months the candidates for the placement of deep brain stimulation electrode, DBS. And therefore, if we refine the selection criteria, this may lead to much bigger success for the right patients.